Professor Sujana and the organizing committee who invited here and be a part of this conference. Thank you so much.
I'd like to remind you that the speakers will each speak for 30 minutes. Thank you.
Good afternoon, dignitaries, the organizers and students of Akal College of Nursing. On behalf of my nursing, that is Christian Medical College and Hospital, Ludhiana, College of, and my Professor Mrs. Punama R. Singh, really thankful. I wish to express my heartfelt thanks that this is the first time I'm here and I have been given this opportunity to present the topic. A few moments back, suddenly few ideas came into my mind when I was just sitting there. Few moments back, Dr. Darshan, she presented her study on breast self-examination, and at that time, I thought that I'll ask a question, and that question is already asked by my student Rupinder, and once again, I would like to ask the same question, that how many of us practice breast self-examination? So, including me, uh, I think all of us don't think it very necessary or important to do it. And why am I asking you this question? Because I wanted to correlate this with whatever is written here, that is my topic, sepsis and septic shock. Basically, though it is written here, newer approaches, but I think that uh, the traditional techniques, the original techniques, and many of the nursing procedures that we have studied in our school time and school of nursing and college, those techniques need to be repeated, reviewed, revised again and again. And I feel that itself is a new approach. That means we need to educate the community regarding the techniques that help in prevention of sepsis and septic shock. So, because that is the most important thing. That is the prevention part in sepsis and septic shock. So when prevention is there, no sepsis will be there and septic shock will not occur. And the other thing is for we nurses, midwives or obstetrical nurses, that whatever techniques we adopt, that should be adopted properly. So in the prevention, starting from cutting of the nails of the woman, teaching her to cut nails, wash hands before and after defecation, uh, before doing the perineal care, after that, before using a sanitary pad, after it, and all the other hygienic techniques that we can teach a woman. We should emphasize and re-emphasize on that so that she does not suffer from sepsis. And besides that, nurses are practicing and obstetricians, when they are practicing simple procedures starting from cleaning the perineum, washing the perineum, sterile things, for example, cotton swabs, cotton balls should be used. If it is a home delivery, then at home even swabs can be boiled and kept for the time of delivery. Linen cloth can be boiled and dried and kept so that it can be used for delivery. And 5 C's, 5 cleans, we have already studied. Besides that, procedures like doing PV examination, uh, artificial rupture of membrane, amniocentesis, then DNC, that is dilatation and curettage, and so many other procedures. When all these procedures are being done, then we need to be assured, we need to assure ourselves and be sure that whatever equipment that is being used, it should be sterilized properly, autoclaved properly, so that we don't introduce the infection. When the mother is coming to the antenatal clinic and otherwise, we make sure that she does not suffer from any kind of infection. She should be taking good diet. She must take the tetanus toxoid injections and the iron preparation, calcium preparations, whatever is needed for maintaining her immunity of the body. If the immunity is maintained, she will not suffer from maybe hepatitis or malaria or typhoid or many other such kind of infections that can be a source of sepsis. So I'll begin with my topic. Please change the slide. So you can see the picture of sepsis and septic shock. I will begin with the definition first. So sepsis, as you see, the other name for sepsis is septicemia, and when there is entry of bacteria in blood or entry of viruses in the blood. Entry of bacteria will be bacteremia and entry of viruses will be viremia. So when this happens, that means there is insertion of bacteria or virus in the bloodstream. So when there is entry of virus or bacteria in the bloodstream, that is septicemia or sepsis. And when it is further complicated, it leads to septic shock. So what is septic shock? It is a serious medical condition due to sepsis in which chemicals are released in blood to fight infection and cause inflammatory responses. So, what is septic shock? Before the septic shock, a pathophysiological mechanism begins. And what is that mechanism? In that mechanism, what happens as soon as the viruses enter the blood due to any reason? I have already told you so many reasons or techniques in which contamination is there, and due to that entry of infection will take place. And because of that, once the bacteria or virus enters the blood, there is inflammatory responses, and when there is inflammatory responses, certain chemicals are produced in the blood. And why those chemicals are produced? In order to fight the infection. Just like antigen antibody reaction. And when this happens, there will be certain mechanisms, for example, clotting of blood. Some of the thrombocytes may be damaged and affected, and that will lead to clotting of blood. And this, once the blood clots, when there is clotting of blood, what happens? That will reduce the blood flow. When clots are there in blood vessels, the flow of blood will be reduced. And when this blood flow is reduced to the limbs and the internal organs, what will happen? The oxygen supply is depleted, as well as the nutrient is also depleted. And it will lead to further changes, that is reduction in the blood pressure and multi-organ failure, especially the liver, kidney, lungs, heart and the brain. And when these vital organs are affected, that will lead to so many symptoms also. And this is one indication for us, we midwives, that the observation of symptoms of septic shock is the first and foremost thing where we can, or step, where we can prevent shock into going into a further serious problem. So if we are able to identify the symptoms early, we can save the life of the woman. So all this will lead to death if it is not treated. So these are the great things you can see here. These are the great things that are responsible for sepsis and septic shock. So very commonly about 75 to 80% of organisms, they are the gram-negative organisms that would be causing sepsis and septic shock, and E. coli is the commonest, 50%, and others are Pseudomonas, Klebsiella, Proteus, Bacteroid and Aerobacter aerogens. And gram-negatives are also there, that is Staphylococcus, Streptococcus and anaerobes, etc. About 20%. So this is a figure of different organisms besides, including syphilis and gonorrhea organisms. So what are the conditions in which sepsis and septic shock occurs? So first of all, they have talked about septic abortion. We know that when an abortion is being done by an untrained person, she may use unsterile technique, unsterile instruments, and unsterile articles or certain things. For example, pieces of wood to be introduced into the cervix, and in order to cause abortion, or tents, sponges or tents that may be contaminated. Such kind of things may be used, and that may further lead to ascending infection. Once Once there is infection, ascending infection, via the fallopian tubes. Via the fallopian tubes, the infection can even reach the peritoneum, and it can cause septic peritonitis. Besides that, sometimes infection can be of the chorion and amnion, that is, when there is premature rupture of membrane or prolonged rupture of membrane, and besides that, unsterile technique of doing PV examination again and again. So that can cause infection of the chorion as well as the amnion. Then affection of the pelvis of the kidney or the nephrons of the kidney, pyelonephritis. That can be secondary infection also, or the mother may be suffering from it before pregnancy also. And besides that, postpartum endometritis. So endometritis. So these are certain conditions that can lead to septic shock. Coming to the pathophysiology, it is a simple thing. First of all, because of those conditions, first of all, the techniques. If the technique is not an aseptic technique, that will lead to infection, and this infection can come in the blood via the vagina, cervix, uterus, fallopian tubes, or it can be due to other reasons, for example, abscess of a breast, and even in puerperal sepsis. So infection can reach the blood due to certain direct diseases or maybe ascending infection. So one is in the blood, entry of bacteria takes place in the blood. What will happen? Bacteria begins. And what do the bacteria do? They start producing certain agents that are known as endotoxins. And these endotoxins have effect on the capillary network. The bacteria, they produce endotoxins, and the endotoxins cause effect on the blood capillaries. And what is the effect? The effect is vasospasm. So that there is pooling of blood in one part of the capillary, and at the other end there will be constriction of the blood vessel. So vasospasm will lead to pooling of the blood in the capillary, and because the blood is pooled in the capillary, this pooled blood is not moving forward. That means venous return is affected. And when the venous return is affected, that means the cardiac contractility is decreased, and enough blood is not entering the blood, so cardiac output will also be affected. In other words, myocardial functions will be decreased. Myocardial functions will be decreased. And this further can lead to cell damage. And not only this, we had talked about endotoxins. The endotoxins, they further lead to damage of the cells. And once the cells damage, they cause biochemical changes, complex biochemical changes, and one of it is clotting of blood and infection. Okay, and presence of metabolites. They are cytokines like tumor necrotizing factors and interleukins. These are the cytokines that may cause the damaging of the cells of the body. So metabolites will collect, and that will lead to further damaging of the cells of the body, and due to damage of the cells of the body, many other effects will be there, and major effects are damaging of the major organs, that is the lungs, the heart, the liver, the kidney, as well as the brain. And this will finally lead to mortality of about 30 to 100%. So we were talking about shock, and shock can be broadly divided into two phases, that is phase 1 and phase 2. So the phase 1 is the initial phase. This is the reversible phase. We can reverse the condition of the woman. We can help to revive the woman back into normal state. That is the reversible state or the initial phase. And it is also known as warm shock. And what are the things that happen here? It is, there is mild vasoconstriction with compensatory mechanism operating. Because of the compensatory mechanism, constriction of the blood vessels will occur. But it will be occurring mildly. And then at this stage, in the initial stage, there will be normal blood pressure. The blood pressure changes may not occur, it may occur later on in the second phase. Why? Because the compensatory mechanism is in action. And then besides that, because of the compensatory mechanism, the pulse rate will increase. That is tachycardia. Why will it increase? Because the heart has to function more. Why has it to function more? Because it has to pump more blood to the different cells of the body. And because there is hypoperfusion and collection or pooling of blood in the capillaries, and because of pooling of blood, the oxygen exchange is not taking place, and enough oxygen supply is not reaching the cells of the body. So oxygen depletion is there, and amount of carbon dioxide increases. And when amount of carbon dioxide increases in the cells, that causes production of carbonic acid. And this carbonic acid can cause acidosis, and because of which we have to give bicarbonates to the patient to balance it. And besides that, there will be sweating, the extremities will remain warm, and patient will appear restless and anxious. So this is the first phase, and next phase is the second phase, that is cold phase or the late shock. In this, when the first phase is not treated, when the first phase could not be treated, it converts into phase 2, that is the cold shock or late phase. And this is the irreversible phase. The patient passes into a state of hypotension. The blood pressure falls down in this phase. In the first phase, it was normal, but in this phase, it will fall down. Patient becomes progressively pale, tachycardia persists, and due to intensive vasoconstriction, the periphery becomes cold and there may be sweating. So these symptoms should be remembered by the nurse, and we should have critical thinking and a sixth sense. Nurses should always have critical thinking and sixth sense, so that they are at the right time, initial stage, they are able to catch hold of the symptoms, so that prompt treatment and reversible change can take place, and we can save the life of the mother as well as the baby. Next. So this is just a kind of animation, and it is a male person has been shown here. So this is just for a general shock because of hemorrhage or neurogenic or anaphylactic, etc. It was not specifically related to obstetric. But here we can see, even though a male person has been shown here, but you can see that in the urine bag, here in the urine bag, the urine is cloudy. So what does it indicate? There is presence of infection, that is E. coli. And because there is presence of infection and urine is cloudy, that means the patient will have rise in temperature. So these are the things that we nurses can observe promptly at the right time and report, so that prompt treatment can be given, besides other symptoms. So this is the warm phase. And the second phase, that is the cold phase of shock, we already discussed some of the symptoms we had seen. And here they have only shown the skin is cold. We can touch the patient and feel it. Patient, this is the part of management. That is, we put the patient on pulse oximetry, we intubate the patient and put him on, Besides that, certain we will see that the blood leukocytes more than 12,000 per ml cube. Cutaneous symptoms, GI symptoms, and central nervous symptoms will be there. Specifically, uh, these symptoms, beside these symptoms, respiratory symptoms are there, that is edema of the airway. Patient is not able to breathe, there is dyspnea, difficulty in breathing, wheezing, cough, chest tightness, hypoxia and confusion. So all these are the other symptoms. If nurses are able to observe these, then we can make a difference. Next slide. So this is also a flow chart regarding shock, but it is related to generalized features of a shock. It is not specific, and they have given shock due to hemorrhage, shock due to fluid loss, shock due to allergic reaction, due to neurogenic impulses. But we are not considering all these. We just would see that how sepsis, that is when there is entry of microorganism, when there is entry of bacteria inside the blood, will cause vasodilation, and vasodilation will lead to heart failure, and heart failure will lead to decreased cardiac output, hypoperfusion, and cell anoxia, that is absence of oxygen in the cell. All these features will finally lead to shock, and shock will affect all these major, that is the internal organs. And because this mechanism already I had told you that there will be acidosis and cytokinins release. And you can see here, these are the symptoms. Because of decreased cardiac output, there will be hypotension, and hypoperfusion of the tissue, there will be cold and clammy skin. Because of the cell anoxia, thrombosis and edema will be there. Shock will finally be observed in the state, that means the woman will be in a state of sleepiness, or she may go into coma. Shock will also lead to renal failure, that is less amount of urine, less than 30 ml per hour or less than that, difficulty in breathing, and the GI symptoms uh, because of the certain cytokinins that are released and acidosis, that will cause GI symptoms as well as bleeding, that is hematemesis. And this hematemesis will lead to pyloric stenosis or pyloric ileus. So all these symptoms affecting the lungs also, acute respiratory distress syndrome, and that will lead to death due to cardiopulmonary failure. So this is the physiological mechanism of septic shock. So now we come to the management approaches. Approaches are all the same, the traditional or original approaches that were being used since ages, all those approaches are there. Besides that, one or two new approaches will be there. So what this study was done by Rivers and colleague in 2001, and it was updated by Dellinger and colleagues in 2008. And after doing a study on a group of people, group of women, they stressed on the same thing. Whatever I had told you in the beginning, they stressed on the same thing. And what is the thing? Prompt recognition of serious bacterial infection. So first of all, recognition. As early as possible, the woman should be observed for the symptoms. She should be observed for symptoms, specifically if she is having very high grade fever, tachycardia, etc. That is an indication of infection. So in those cases, we should be observing for shock. Then close monitoring of vital signs and the urine flow. And hypotension, oliguria, and these are considered symptoms for septicemia and hemorrhage. So if there is septicemia and hemorrhage, that is, what is it telling? that hypertension and oliguria is there. Or in other words, it is vice versa. When oliguria and hypotension is there, that means there is septicemia and hemorrhage taking place. So we come to the next part, that is resuscitation. We all know about resuscitation. I need not to elaborate it. Next. So these are some of the things that need to be kept in mind while we are doing the resuscitation, that providing fluids and maintaining the CVP level to 8 to 12 millimeters of mercury, mean arterial pressure more or equal to 5, urine output equal to or more than 0.5 ml per kg per hour, and superior vena cava oxygenation saturation to 70%. Next. Then lactates. The lactate level should be normalized because acid can take place. Because of the pooling of the blood, acidosis takes place, and acidosis can cause increase in the lactates, acids, and there will be tissue hypoperfusion. So this is the next therapy. All of us metronidazole, and patients who are not able to bear the effect, or they are allergic to metronidazole, clindamycin can be given, and besides that, all this is the alternative regime to ampicillin and gentamicin, that is imipenem, piperacillin, and tazobactam. Next, intravenous fluid, we are very familiar with this also, so IV fluid should be given. Next. Then correction of acidosis, bicarbonate should be supplemented around 50 to 100 milliequivalent. Maintenance of blood pressure. How do you maintain blood pressure? Drugs that are known as inotropes or inotropic agents. Adrenaline, noradrenaline, dopamine and dobutamine. These are the drugs which are known as inotropic. They help in raising the blood pressure, as well as they have antihypertensive effect. Then besides that, vasodilator drugs also may be given in certain cases, that is sodium nitroprusside, if the mean arterial pressure is more than 70 millimeters of mercury. So in certain cases only we can give. Diuretic therapy, we know that in order to reduce the fluid overload, the furosemide can be given, and to reduce pulmonary edema also, we are giving furosemide. Then corticosteroids, specifically hydrocortisone, we know that it has multiple action or multiple effects. One, the most important effect is anti-inflammatory. It improves microcirculation, it reverses the metabolic acidosis, and improves the cardiac efficiency. So these are the effects of hydrocortisone. Then heparin therapy, because we know there is blood clotting in the blood vessels, so heparin therapy has to be given, as well as fresh frozen plasma. Digitalis has been recommended, but not always. It is not a specific treatment. It can only be given when there is features of failure or atrial fibrillation or flutter. Next, then elimination of infection. Hysterectomy may be done, but still it is controversial. Next slide. Then insulin therapy, because there is damage of the liver, and when damage of the liver takes place, glucagon hormone is produced, and glucagon causes glucogenolysis, that is release of more glucose will take place, and when more glucose is released, that will raise the blood glucose level, hyperglycemia. And to control hyperglycemia, insulin therapy is given. Then ranitidine, because acidosis has occurred, so ranitidine therapy is being given, and to reduce the stress-induced bleeding and ulceration. Besides that, nutritional support, that is total parenteral nutrition, and if the patient is conscious, able to swallow, oral also, about 20 to 30 kilocalories per kg per day, besides fat and carbohydrate. Then recombinant, this is something new, recombinant human activated protein C therapy. I am about to finish. Activated protein C is given. Why is it given? To inhibit inflammation, thrombosis and promote fibrinolysis. So this is the therapy that is given, but still it is controversial. And autotransfusion, have you heard about autotransfusion? It may not be specific for septic shock, but when a woman is undergoing a surgery and lots of blood loss is there, then that blood can be taken, salvaged and purified. And the same blood can be transfused to the same woman. So that is this therapy. Next slide. So these are certain researches that have been are showing how to reduce. Here only the approach is the same, that is assessment of the patient timely and as early as possible. Next. So fetal concern is delivery can be delayed as far as possible. When there is chorioamnionitis, then only the delivery can be done. Otherwise, it can be delayed up to 23 to 35 weeks. 25 weeks. Next. Next slide. So, these you can read. These are not recommended. And last of all, next. So, here also they are mentioning that resuscitation is important and timely assessment and evaluation and starting the treatment. This is also a research study. Next. आगे कर दो. So, okay. So these were the two studies that were shown, but they mention all about the guidelines. Thank you so much.
It's a very knowledgeable and very good session or lecture, I say, about shock. I'll just put some more considerations here regarding the research part of view in septic shock. The current approaches says that there is a very simple way of treating the shock. What ma'am considered, just need to symbolize that. The ABC we all used to heard, airway breathing. That is what the current approach the researchers have what ma'am suggested in that. And F stands for the fix the source of shocks. So that ABCDEF has been suggested by many of the researchers in current perspective. Thank you, madam.
But the sad thing about septic shock is I don't think the treatment much from when I was intensive care units in the 70s. And so we really haven't come shock so that.
Thank you, ma'am. The next is Dr. Avinash Kaur Rana to speak about the effect of midwifery of care on maternal health during the postpartum period.
Then means it's near about 40 years I have spent in my clinical practice. I have seen the nurses is not having the habit to talk with the mothers, even in labor room, even in antenatal clinic, and even in the postnatal ward also. And the mental always ignore. Even in the, we can say the, when we are talking about the national level or international level, what are the strategies we have to adopt so that mother should not have the mental illness. Because when I do the presentation, it is indicating that if the maternal health is going to be, or the mothers having the we can say that any depression during the postpartum period, it may lead to longer life also, and it may affect even the growth and development of the newborn, or we can say later in the life of the child also, and the child may be going to develop some psychiatric problem or behavior problem is there. So let us, we can see, and I'll try my best to make myself to understand, because first time I'm explaining this model, and maybe the very senior most teachers and we can say the nursing personnel are sitting. and they can add also if at the end of my presentation. So the topic is that is the effect model of maternal mental health during the postpartum. I am going to say about the midwives model of care. Now, in 19 May 1996, many representatives from the Midwives Alliance of North America, that is MANA, and North American Registry of Midwives, that is NAMS, and the Midwifery Education Accreditation Council, MIAC, and Citizen for Midwifery, they work together and write the definition of the midwife model of care. All groups could use consistently in communication with the healthcare decision maker. Now, this midwifery model of care, the midwife model of care is based on the fact that pregnancy and birth are the normal processes. Will include the monitoring of the physical, psychological and social aspects, providing the individualized education, counseling and we can say prenatal care, continuously hand-on assistance during labor, delivery and postpartum period. It also minimizing the technological intervention, identifying and referring the women who require the obstetrical attention, and this model is purely woman-centered model of care which prevent the birth injury, trauma and the chances of or incidence of the cesarean section. Now, as this model is woman-centered, so midwifery care is uniquely nurturing hand-on care before, during and after the birth, and midwives are healthcare professionals specialized in pregnancy, childbirth, who develop a trusting relationship in their client. Now, this is the perinatal maternal health promotion model is there. Now, as you know, this model is indicating that how this during the postnatal period, or not only the postnatal period, even the perinatal period or antenatal period, how the mother is going to be remain the healthy postpartum period. And healthy postpartum period is going to be remain when the mother is going to be recovered from the physically recovered is there, and she is able to care of self, infant and family, and she is going to be aware or the maternal role during the postpartum period. And this is going to be attained by the second circle, which is saying that self-efficacy. Self-efficacy means it is the confidence of the mother to look after herself and give care to the baby. And by adopting the positive coping strategies and realistic expectation to the role change of the mother after the during the antenatal, we can say during delivery and after birth, and mobilization of the social support is there, nurse and other personnel. So we can say these three inner cycles are the key of the maternal task of healthy postpartum period. The rings around these tasks included the core individual skills that are needed to ensure that the task successfully accomplished, and the outer ring represent resources that a woman may need in order to successful required, or we can say employ her individual skills in order to accomplish the task of postpartum, which include access to clinical services, social, other support services, information and material services. I request to the in the hall, people are sitting, please listen quietly. So much noise is there, and it may be interfering with the presentations, and please bear with us. I know it is too late. Now the physical, as in this circle, the physical recovery of the mother is there. So mother is going to be recovered from the during childbirth and during pregnancy also. Like we can say, there is so many changes, physical and the emotional changes are during the time of postpartum period. And along with that, meeting the needs of the mother, including the social needs, infants and other family member. And now in the postnatal period, she is going to be attain the successful maternal role. The physical recovery is that is involution of uterus return or body systems in the normal conditions, and mostly it is going to be lead up to 6 to 8 weeks of postpartum, and maybe the completely anatomical and physiological changes will take place within 2 months, or maybe it will take 1 year also. Common concern of women in postpartum period, that is, as a nurse we should see that immediately after the delivery, physical mother may be have fatigue and sleep disturbances there, and she may be going to have the pain, like pain in the perineal area, that is maybe in seasonal area after the cesarean, and pain in the breast also due to engorgement of the breast, and pain in the nipple also. When engorgement of the breast will be there will be pain in the nipple will also be there, and mostly they will have the headache and the backache. So we can say that as a nurse, as a health professional, mother should have attained in hygiene, nutrition and weight loss. Now psychosocial concern is that is the mother's maternal role attainment to the infant has to be going to be arise in the postnatal period, and as the body self image is changed during the postnatal period, and so mother may be potential to have some problem also. Marital and intimate relation may be going to be disturbed during the postpartum period. Care of infant, house and family, that is infant needs feeding, she is able to give the feeding to the mother, identification of signs and symptoms of infant illness also, and she is going to be attain her housework also in cooking and cleanliness, need of to look after the other children also in the family, and we can say the household logistic, that is transportation and child care, if child is going to be sick and she has to be take the child in the hospital, so these are the things she has to do. So there are phases of maternal role attainment, because that model is said the maternal role attainment will be there when there is a we can say healthy postnatal mother is there. So first phase is taking in, that is the mother focus on own needs and may need to tell and retell the birth story, may take some times accepting the newborns and as hers, may not feel maternal and may see and may seem passive in the maternal role, may not be very responsive to the to attempt by others to get her to take on active role in newborn care, and may not educational messages also. Second phase is that the taking hold, that at about day third, mother will become very interesting in taking charge of newborn care and may seek perfection in her maternal role, caregiver role, and we can say vulnerable to feelings of inadequacy, may become anxious and preoccupied with ensuring that she is doing everything right, will be open to education, but this need to be provided in a way that does not erode her self efficacy. Third phase is the letting go. Mother may go through the broad range of emotions from the despondency of euphoria as she comes to accept the of her new maternal role and let go of her old self to accept this is normal phenomena. So individual health enhancing skills is there. 4 skills is there, that is consistency necessary for the woman to successfully exercise, and second is that control over their own and infant's health and we can say other family members in the postpartum period. Individual skills are, that is effective of social support, self-efficacy, positive coping, and realistic expectation and goal setting is there. Effective mobilization of social support is, that is the social support is assistance that individual provide and receive other by close relation and professional appears to have a positive effect on physical health and as well as the psychological well-being of the mother. Now category of the sport is, that is emotional sport, instrumental or informational sport is there. Emotional sport is that what individual do or say to make other individual feel loved, supported or encouraged. Instrumental sport is when individual provide needed material resources or assist to or complete a task or for another individual. Assistance with task social sport is also thought to impact on health positively by reducing the degree to which the life events are perceived as stressful by an individual and by enhancing feeling of self-esteem and self-care. Now, informational sport is sometimes mentioned. It is the literature informational sport included the model as an external resources also. There are many barriers are there which affected the social or mobilization of social sport. Maternal perception that ask for help will reflect the poorly on her parenting ability, fear of being perceived as a burden, fear of hurting people's feeling, for example, by asking instrumental assistant different than what is being offered. Others would not be able to relate to her experience and thus not to be able to offer adequate support. Healthcare providers that help promote postpartum health. Self-efficacy is a part of, we can say, in the model, and self-efficacy is a person believes in their ability to perform the particular behavior successfully. An expanded definition self-efficacy is that an individual's ability to achieve goals has been proposed by others. In the postpartum period, self-efficacy is positively related to the health-seeking behavior and inversely related to the maternal stress and the depression. Self-efficacy is only a key skill in maternal role attainment and woman ability to competently perform infant care and other parenting tasks that depend on her confidence in her mothering abilities. So, maternal self-efficacy is also closely linked to the child development. So the factors effect on self-efficacy, direct experience, similar task, seeing others perform the task, infant temperament, and when confronted with the difficult task, individuals with lower self-efficacy will avoid or give up the more easily, which in turn further decreases their self-efficacy. Now the positive coping is another things which is shown in that model. Positive coping is an adaptive response by an organism to adverse circumstances from human behavior perspectives. Coping is an effort to manage and overcome demands of experience that pose a challenge or threat of harm, loss or benefit to the person. Coping can occur in response to reactive or in anticipation of the proactive demands or the problems are there. So this I will not discuss in detail. Realistic expectation and goal settings. That is, the main goal as provider in this arena is to better prepare the mother for the demands of the postpartum period. A proactive, honest, reality-based approach aimed at altering maternal expectations of both the postpartum be directed to counteracting the feelings of inadequacy often experienced by new mothers. Normalize the experience of feeling overwhelmed and uncertain by letting her know that these are the feelings that are almost inversely expressed by the woman in the time period. Provide information on wide variation of normal infant temperament, including feeding, crying, sleeping, and other. Now, realistic expectation is a normal adaptive human response, modulated individual behavior, allowed for efficient and effective interpersonal interaction. Expectation based on incomplete or incorrect information conflict the reality of situation the individual. Postpartum period affect woman ability adjust to motherhood and we can say to other transition following the birth. Now, we can say that now this midwifery model, this is the modified midwifery model care is there. So, they have shown the different colors of, in the center maternal health is there, that is three aspects it is there: physical recovery, care of self, infant and family, maternal role attainment. And blue, it is indicate that we can say that this purple color is also in entering into the blue one also, because if this efficacy will be self-efficacy, positive coping, realistic expectation is there, mobilized social is there, sport is there, then we can say the maternal health is going to be best in the postpartum period. And if there is a helping people are there, education is there, then we can say to prevent from the maternal postpartum depression. So if this model is, or we can say the mother is not going to have all these things, what is going to happen? So they are going to arise postpartum depression, or we can say postpartum mood disorder. Why? And so we can say the postpartum depression is highly prevalent, and it is not a time limited, and major risk factors for an infant development, and it is highly treatable. Postpartum get most of the time it does not get the treatment. So we can say the three problems are there, the like baby blue is there, postpartum depression, postpartum psychosis is there. And there is a reason why baby blue is there. That may be two reasons: abruption, hormones withdrawal is there, and there is a biological system undergoing the attachment. Now baby blue is being mostly, it is we can say remain few weeks, and and mostly it is going to be recovered within 15 days, and we can say it is highly prevalent. 80% women they will have this baby blue. So symptoms are crying, weeping, sadness, irritability, exaggerated sense of empathy, and we can say anxiety will be there, more mood liability is there, feeling overwhelmed, insomnia, trouble falling or staying asleep, fatigue, exhaustion and frustration. And so if the baby blue is not going to be treated, or we can say ignored, the mother is going to have the postpartum depression. And usually this postpartum, we can say onset is usually within first 2 to 3 months postpartum, through the onset can be immediately after the delivery. So we can say that 10 to 20% prevalence is there. What are the symptoms are persistent sadness, frequent crying, even about little things is there. For example, she is not able to give the breastfeed to the baby, the mother is going to be crying. So these are the small things. So poor concentration will be there, difficulty remembering things, feeling of worthlessness, inadequacy or guilt feeling will be there, irritability, crankiness is there, loss of interest in caring of oneself, not feeling up to doing the everyday task. Psychomotor agitation or retardation is there, fatigue, loss of energy, insomnia or hyperinsomnia is there, significant decrease in or increase in appetite, anxiety manifest, bizarre thoughts will be there, fear such as obsessive thoughts of harm to the baby also, feeling overwhelmed, somatic symptoms will be going to be arises, and recurrent thoughts to suicidal idea will also be there in this. The risk factor is that there may be biological vulnerability is there, and psychological factor, life stress is there. Biological is rule out others medical problem, anemia, thyroid, and because these things if it is there, the mother is having more risk factor is there, and more depression is there. So hormones fluctuation including stress hormones, fatigue and prior history of depression. So these mothers are more potential to have the postpartum depression. Psychology and life stressor is another factor is there. And so we have to say, did you know over 1/3 of mothers caring for toddler experience depression is there. So, psychology, women who have never been depressed, there is a chance of 10% women they are going to develop the postpartum depression, and women who have been depressed, 25% again they are going to develop the postpartum depression, and women with previous postpartum depression, 50% their chances. Here it is that this shows that where low income mothers will be there, they are going to more depression during pregnancy. So this depression, postpartum depression is going to be effect on the mother suffering, a lack of joy in child care, lack of confidence in parenting ability, miss the work also, social withdrawal, somatic symptoms, guilt, and we can say suicidality is going to be increased. The father is also going to be affected. So each family member is going to be affected. Increase anger, conflict with others, increase use of alcohol, drugs and misuse of isolated from the family also, feeling discouraged, impulsive, reckless driving, extramarital relationship, physical problems, headache, indigestion, work consistently or worry about the performance at work, conflict between how he thinks and he should be as a man and how he actually is. Family problems are going to be arises, marital discord, withdrawal from the other family members, challenging relationship with other children. Mothers, those who are having we can say that they are potential to preterm birth, low birth weight babies, and miscarriage and preeclampsia. So the children are also going to, infant is also going to be affected, and do the baby have mental health, and later on the baby may develop mental problem also. And impact on the maternal depression on developing child is, if it is seen that when compared with non-depressed mothers, that is, depressed mothers demonstrated less affectionate behavior, less responsive to the infant cues, and more flat affect withdrawn. So the children in later age also, the children is going to be develop the problems. So it's very important. So be screen. I'm going to finish it. So we can say that as a nursing, as a nurses, we should use this Edinburgh postnatal depressive scale. It is only 10 items is there, and so we should learn how to diagnose the postnatal postpartum depression is there. So this scale can be used also. So treatment is psychiatric treatment, or we can say social support, hormones, and psychotherapy is there. Thank you very much. Can you remove it? Thank you for patient listening. Patience.
Do you want to say, ma'am? Now I would like Dr. Jane Green, ma'am, to current research findings into the care of gynecology. Okay. Yeah.
All right. All right, everyone. Thank you very much for being attentive. So this goes forward. Okay, good. As it's late, I'm very fast. A little bit depressing what I have to say. It's evidence can actually do to help impact this global issue. So there's an agency within the World Health Organization called IARC, or International Agency for Cancer Research, that looks at the incidence of cancer, all different kinds of cancers, globally, and then breaks it down country by country. So 12, but I'm going to be talking just specifically about cervical uterine cancer because breast health was discussed earlier. So in 2012, you can see that 850,000 women were diagnosed with cancer, and of those, almost 1/3 of them were in India. So clearly we have a lot of work that we need to be doing. In that same year, 350,000 women died, of which approximately 20%, 22% were Indian women. 75,000 Indian women died of cervical cancer in 2012. That's a lot of women, a lot of moms. So there's a very clear link between HPV, human papillomavirus, and cervical cancer. It's absolutely been linked. And nurses have vital roles that we can play in education, vaccination, prevention strategies, screening, and then referring women for HPV, women who screen positively, refer them for treatment. So in terms of prevention, one of the most basic prevention strategies is education. And something that's a little bit difficult for people to discuss is that HPV is transmitted sexually. So it's difficult for nurses sometimes to discuss with their patients, particularly if you have a married woman in front of you, the possibility that her husband might be straying outside the context of her marriage. But we need to practice that. We need to figure out ways to discuss it. So we need to examine our own feelings so that we'll be able to discuss it with the women we take care of. Because HPV, cervical cancer, death, we don't want our patients dying. So in order to prevent their deaths, we need to deal with our own discomfort about discussing difficult issues, including sex. So we also need to advise our patients to use condoms, the importance of screening, and the risk of death due to cervical cancer. Another prevention strategy is vaccination, particularly vaccination of all teenage girls. So just because we vaccinate girls with the HPV vaccine, and I'll talk to you about what some researchers have suggested about how inexpensive it would be to vaccinate girls and how many lives we could save. But just because someone has been vaccinated does not necessarily mean that they won't get HPV. So vaccination covers some of the strains of HPV, but not all of them. So even if someone has been vaccinated, they then also need to have screening. So there was a researcher group, Jet et al., who estimated that there are 179 countries that the World Health Organization has designated as eligible for inexpensive vaccines of various kinds. So of these 179 countries, of course, India is one of them, and they estimate that if we would vaccinate 58 million 12-year-old girls, we could prevent almost 700,000 of cases of cervical cancer or prevent nearly 450,000 deaths, and it would cost only $4 billion US, which is not all that much compared to what the US is spending on all kinds of other things like the war. So vaccinations are cost-effective and life-saving. So to talk about screening methods, we all know about Pap smears, that's very common, but there's some new screening methods that are also being used. One of them is visualizing the cervix, so it's the same thing, it's using a speculum, it needs to be done by a trained provider. It involves a speculum, a light source, and then looking right at the cervix. But if you wash the cervix with a 5% vinegar solution, abnormal cells will brighten up and turn bright white. So then you would know it's just a basic screening test to screen for whether or not that woman has cervical cancer. This visual inspection with vinegar, or VIA with acetic acid, there have been trials. In some places, some trials have suggested that it has some rates, including a trial that was done in India where they found there was a 35% reduction in cervical cancer deaths using the screening method, but other studies also done in India did not support that. So let's talk about another method that's actually quite brand new, evidence-based. This new screening method can be, the thing I think that's interesting about it is that this screening method can be done either by the woman herself or by a provider. So it's a swab, it's like a Q-tip that the woman can just put inside her vagina, twirl it around, put it into a medium, and then the medium gets sent off to a lab. It doesn't require, the medium doesn't require refrigeration, it doesn't require the woman going into a clinic, it doesn't require a light source. It's very new, and it's been trialed, and I'm going to talk about some of the trials that have been done, including some trials in India. It can also be collected by a provider, basically the same way as one would do a Pap smear, of looking at the cervix and then using it's called Care HPV, that's the name of the product, can be done either by the provider or by the woman herself. And there was a group of 5 studies that were done in China that found that, this is a little bit surprising, that the woman collecting the specimen herself was just as effective as having a provider collect it, which as providers we all like to think special, but perhaps some things we aren't necessarily needed for. Also studied women from Nicaragua, and 4 techniques. They did the vinegar wash, they did the HPV smear, the swab that the woman could do herself or could be done by the provider, and they did a Pap smear. So they compared those 4 different methods, and what they found was that the HPV swab was actually more effective than the Pap smear. Very surprising, and much more effective than the vinegar wash. So in terms of incidence and how, to what degree women in India are at risk, 17% of the women from Uttar Pradesh screened positive, and 21% of the women in Hyderabad screened positive. So that's almost 2,100 women. So what, as nurses, what exactly can we do? Because clearly this is a problem. If we have 75,000 women who died in 2012 from cervical cancer in your country, our country, I consider it sort of my country as well in a way, since I have adopted you. So clearly it's a problem if 75,000 women at least a year are dying. And perhaps it's even more women than that because we know that not very good records are necessarily kept. So 75,000, most researchers would suggest, is underestimating. So as nurses, there's actually quite a bit we can do. The first thing we do is we need more nurses. The World Health Organization tracks the ratio of one nurse per how many people for whom they're responsible. In India, it's one nurse for 10,000 people, that's a lot of people to be responsible for. So clearly we need more nurses. We need more nursing schools. We need more nursing faculty. And we need to, particularly faculty who are trained to train students in midwifery and in women's health care. We also, I think most importantly, need to open up this discussion about sexual transmission and do role-playing scenarios, practice sessions, such as what you saw Dr. Sandy and Jamie doing right there. We can be doing that in our classrooms, of having one person pretend to be a married woman who's coming in and is a little bit shy and reserved and doesn't want to talk about anything, and then the student, whether it's a faculty member acting as a student in this time, because as faculty members we also do professional development where we have to practice doing things which are difficult. So practice having, excuse me, this conversation. So we need to be willing to open up and discuss these very difficult topics of sexuality, and particularly the implications of people not being faithful. In terms of our clinical practice, clearly we need to train more women's health care providers. We need more midwives all across the world, including India. And I think most importantly, we need nurses and midwives who are willing to take care of those who don't have anybody else taking care of them. So it's easy to go into a private practice where you just have nice, healthy, pretty women. But I think it's even more important to have the ethic within nursing, within midwifery, that someone needs to take care of vulnerable populations of women, including sex traffickers, women who work in the sex trade. So we need to open up the dialogue, this whole sticky wicket, the elephant in the room of not being willing to talk about these issues. That needs to be eliminated. We need to start talking about it. So we need clinical providers in both rural areas as well as in the inner city. And I think most importantly, and this is where I'm going to end, because I think it's the most important point of all, is we need, excuse me, we need more research around what are the barriers for ourselves around being willing to discuss sexuality, HPV, hepatitis, HIV/AIDS. What are the barriers of our patients who are coming to us? So what is it that keeps, why do we have these numbers that are so high when we know that they're screening, including screening techniques, vinegar, or the HPV, which can be gotten for very inexpensively, or vaccines. So we need more research, more dialogue around what it is that keeps these numbers rising. So we need barriers for screening and barriers for treatment. So much more research. So clearly we have a lot of work to be done, and thank you very much.
Thank you to all participants.
And the programs. For that, request Ms. Pariksha and Ms. Sankita to start with the cultural events.